it's exciting right now. So as I intimated, this is just literally a presentation, kind of a broader overview. And as I said, at any time, I will defer to you all or leaders if there are questions, but happy to answer impromptu, or if I guess the moderator sees a hand, I'm happy to stop and talk. But I also want to give a kind of a high level overview, just a lot going on in our county. And the things that I am going to review this evening are things that I'm imagining have been on your minds and hearts for the good or not. But I thought it was important for you all to know, particularly with NAMI's advocacy and background and interest in some of these other programs. So that's really why some of these areas were selected. And a lot of this information actually was shared with in a joint public protection as well as a health committee recently in the Board of Supervisors. So this is a variation of that. I will focus on things that you might be of interest to. And so what I hope to give an overview are these key areas in terms of what's happening. I'm sure you have heard, hopefully, of Care First Jails Last. If not, I will talk about that. But there's several initiatives that I'd like to review with you this evening. So first, for those who have had the opportunity or has been in this space with me before, I always like to start with a departmental overview, because often folks not forget what we do, but the scope and the breadth of all that we provide is often lost. We are not our best a public announcement in terms of what we do, and that's something that we're working on improving. But these are the systems of care in terms of where and how how we approach organizing our service delivery. The department itself is very large. It's over $500,000, billion. So it's a very large department that I oversee, and each of the services that we provide are designed initially to provide services to those that are severely mentally ill, those who have Medi-Cal or are underinsured or just don't have the support. And for those that are familiar with Mental Health Services Act, that did allow us, when that Proposition 63 was passed several years ago, to expand and just provide services that can engage people before they have challenges. So these are the areas: child and young adult, elder adult, substance use system of care. Integrated services is something also that we provide or coordinate that we often don't give a lot of attention to. And just what that means is we do work with hospitals. We work in emergency departments. We work in primary care clinics. Sometimes either our staff or we will fund psychiatrists, psychologists, case managers, peers, whatever we can that welcomes folks if they have behavioral health conditions or challenges, so that if they prefer to see someone in the privacy of a clinic, they may never know that behavioral health was in the background. But we do that as well, and pharmacy services countywide for all of our beneficiaries. Crisis, people are often familiar with that. The CAP program or new programs that we launched over the last few years. And then we have a new system that I commissioned and was developed in this last year during COVID, the Forensic Diversion and Reentry Services System of Care. And the goal of that system was literally to help people never go back to jail, to not be in jail, to be connected to services and supports. And this also includes juvenile justice and JJC in the county. So these are all the primary areas. We certainly provide so much, but I thought that these are really helpful overview of the type of systems. So because of the funding, as I said, with MHSA and other things, that we don't just only serve SMI, but that is our target population. In terms of the other side of what we do, there's the infrastructure. So we have the services, and then how we basically do this work. And as I mentioned, it's a very large department, over, I believe at this point, close to 600 million, so over $500 million. And we need infrastructure. So there's financial, quality management, Mental Health Services Act, our data. We are replete with a lot of data. So in real time, we can take pictures, quote unquote, of what's going on with our beneficiaries, and that's through also technology, IT, as it's referenced here as information systems. So I mentioned that because one of the things that comes up oftentimes people ask is about whether we have data and information, we absolutely do. One of the challenges is that, and that's why I even sometimes take a chance to reiterate or describe again, is the way that county mental health systems were developed. They were actually developed, I'm going to use these normal everyday terms, as an HMO. And as we all know, for those that have the privilege or the burden of going to an HMO, HMOs often exclude you. They look and they listen to your symptoms, they see what's going on, they tell you what you can have and what you can, or they try to, and their responsibility is to make sure you do get the care. So mental health systems were designed that way. So they often exclude people as opposed to saying, come on in, come on board. So again, MHSA has helped to redevelop that. We've launched a lot of initiatives to change that. So it's not an exclusionary mechanism to say, these are only the people we serve. We're really trying to catch preemptively people before they're having challenges, and even in the quote mild to moderate, or in the primary care medical clinic. So I thought that was important to know in terms of context for history. The two that are just growing off my screen, I don't know if they are for you, are crisis services and forensic and diversionary systems. And again, I emphasize that because clearly people have seen what's going on in justice involved world. There is a lot happening, certainly with wherever you fall on the political spectrum, with the death of George Floyd. There's been lots of gun violence. There's a lot of work here. And again, emergency services have been really a primary place where we focused in the last few years. So specifically, these are the areas that are happening and really moving for key initiatives. And as I said, I'm humbled. We have certainly myself as the senior executive leader over the department, but I have many different leaders and staff and team members, consultants, everyone really coming together, because it's a Herculean amount of work that has to happen to system change and really do something different. What I didn't mention, for those that are interested, is that as a HMO, and we are basically a two-part at HMO, we're a mental health system and we are a substance use system. And when you use them both together, that's where you get behavioral health, because we do and oversee and are state mandated to do both as a provider. So we will and have already started launching a strategic planning initiative. And I do hope at some point, many of you in different contexts receive surveys or invitations and to share your voice. We hope that you really take advantage of that. And as I meant what I said, I always love positive feedback, but if it's not, I will duck, because the main point is to hear from the community about what's going on. The Community Access Redesign Project, that is a project, and its access is in all caps. And believe it or not, it's been a unit that's been around at least over 20 some odd years in the department. My predecessors created the division. And initially, as I mentioned before, its goal was to receive referrals. And then if people, quote, meet criteria or eligibility, receive services. And if they do not, refer them out. There's the HMO dynamic. We are in the process of undergoing the significant change to change that because we're finding that, again, people are getting more ill. People are more seriously mentally ill. They're getting more ill earlier. Our young people are suffering in terms of trauma. What we're seeing, COVID just highlighted a vulnerability and exacerbated. So there's so many reasons why this is the right time, and it's just the right thing to do. So we are currently doing that. So we'll be changing the way people can access services and helping our partner CBOs, community behavioral organizations, the folks actually do the work, most of it, to be able to immediately serve as those community portals. So people need not always have to call us. They may be able to call our partners and they can receive services. So that's what referring to. The other piece I wanted to add to that is for all of our substance use services. So out of that, again, very large budget, all the programs that we run that are serving our substance use clients and families are contracted out. So we rely on 100% at this point, all of our contract providers. For mental health, it's about 87 to 88% of our providers are in the community. So oftentimes we're, again, slightly humble. We don't always acknowledge what we're funding and what we're doing. But when the system is challenged, we take ownership on that. We also share that strategy and pivoting because many of our providers are actually the ones doing the work. So we really have to rely on making a change that includes them. I won't spend a lot more time on these because I've mentioned the hospital initiatives. We're really partnering with some local hospitals, creating ways for people not to stay in the ED, to have programs that can immediately go into a hospital and without obnoxiously interrupting hospital operations, but referring them out to a program that can link them to where they need to go so they don't have to languish in an ED. We also created during the pandemic, I believe it was September of last year, a health equity division. And for all the reasons that I mentioned, I presume I won't need to refer more. That's probably for another whole topic. But what we found is that people were overly represented, particular demographics, socioeconomic risk factors, racial, gender, all different inequalities that we're seeing in the mental health system. So our division is really holding us accountable and is starting to make some recommendations on how we can change services and everything else. And again, I'll spend a lot more time around the forensic and some of that work. And this was just a highlight, excuse me, a little fast on that, a highlight of the crisis assessment and treatment teams. So I won't go into that one too much, but that's one of the programs we launched again during the pandemic, where we're pairing an EMT, a paramedic with a clinician. The whole goal is to keep people out of John George if we can, or if they need to be medically cleared or taken somewhere else, to do that. So those have been really the strategies that we've been trying to work on for the last several years since I've returned back to the county and beyond that. As I mentioned, I won't again reiterate these areas, but this is really the opportunities that we see for system change. What I will highlight that I haven't already mentioned are funding opportunities. I'm sure people have seen or heard that the governor has released millions and millions of dollars back into the states and counties. We are trying at every turn to take advantage of those through grants. There's what's called the BCHIP and the CCE, Community Care Expansion. And I don't know why it's BCHIP. My brain always breaks. It should say BHKIP or something to me, but that's the behavioral health, I think, community investment or project. I apologize, I don't recall. But the point of that is capital expansion. So multiple millions of dollars have been released to the state, and counties could apply for them to build and create mental health serving programs and housing programs. So the CCE refers to housing, and the BHQIP refers to, or CHIP, excuse me, refers to behavioral health. We had to endorse, so any behavioral health program or facility that wanted to be purchased or bought had to be co-signed by myself, the mental health director, in every county jurisdiction. Some counties did not apply. We applied for 14. We don't know if we're going to get them all, but we did through people and organizations and community partners, even some cities who had property, because we wanted to invest. It does mean a 30-year investment to anything we build or anything we rehab or anything we expand on, and we're willing to do that because we know there's a need locally. And those are just some of the examples. And then our housing, which is operated through Healthcare Services Agency, also is looking at leveraging other resources to support the homeless population. And then finally, the Care First Jails Last system planning. And I will talk a little bit about that very shortly. So one of the things that keeps coming up is care courts, and I don't think I can see everyone, but are people familiar with care court, or have you heard about it? No. Well, I'm glad that we're going to take the time. I thought this really would be a very interesting and also informative in terms of what's happening. So I will start at care courts, but I'm going to go through the slides, which walks you through a little bit in the comparisons, because there's a lot of advocacy that is happening already. And so what I'll start to say is essentially about 3 months ago, the conversation started, and it was literally completely from our governor. Governor Newsom proposed what's called care courts. And what that essentially is a civil process that will focus on homeless individuals who have severe mental illness. And it's like community conservatorship and assisted outpatient treatment, but it's not. And they will be civilly mandated to treatment. It also provides requirements that the judges and the DA and public defender's office all come together to provide support. Now, there is no funding at all for behavioral health. So that means that county behavioral health will have to figure out, if individuals are court mandated a treatment, how to then compensate for the additional need. There will literally be additional need, clearly, if our courts now require it. Now, what our governor did do was provide millions and millions of dollars to the court system, to the judges, and to build the infrastructure to get evaluators. They could be county, they could be theirs, to help develop a care team. But it will be tricky. So these are my commentary just to help you understand. So this is very separate than anything else, and it is not as assisted outpatient treatment was, which I'll go through, community conservatorship, again, which I'll talk about. It is not an elective choice. It is a requirement. All 58 counties will be required to implement care courts per action by the governor. So this is very important because it will provide another level of a requirement if people that are seen in the community or referred in the community that are homeless, particularly, or have severe mental illness. This is very, I think, at least important. And many community members haven't seen it, which is not surprising. There's so much going on in the world. This slide is certainly not something that I have to go through in detail, but for those that are interested, again, I hope that my slides are of interest to you. This helps to clarify what the difference was to the assisted outpatient treatment and community conservatorship. So I'll start to the left, but I will give the biggest distinction. People who have been conserved by the court. Again, there is an individual through social services in our county who oversees pretty much all of their care, and they now are able to require medications. They are able to require them to participate in treatment, often in locked settings. Most of the time in this county, it is in locked settings. But then a community conservatorship does allow, based on the thing that we did a few years ago, for people to live otherwise. But it is a conservatorship process that is governed by the social services agency. So that is different. Assisted outpatient treatment, and many of you may remember Laura's Law. There were so many things, and there was advocacy. In our county, it was very contentious. I was here then as the deputy director and the interim director, and then I flew away and it got resolved. We implemented prior to me leaving and then returning, but it was very contentious, and we ended up having to do both. And many of our consumers, some of you may remember, were mostly in favor of community conservatorship, and many family members and others that wanted to be able to refer, which is slightly different than community conservatorship. They wanted to refer family members or ensure that they are mandated to treatment and participate in the highest level of care. That's what assisted outpatient treatment here is in the county. They both, basically, a person is in a full service partnership, which is just a Mental Health Services Act funded, and it says 6 moths, but there are no moths in the FSP, so my apologies for the typo I see. But the individuals, essentially, whether you're coming through being conserved or whether you're coming through being civilly required to participate in treatment, they both, essentially, you get similar support through the highest level of outpatient care, which is an FSP. The one difference in AOT that's really striking, and again caused some of the concern earlier on when this was being advocated for, is AOT does not force medication, nor can it force medication adherence. So though family members and others often use this as a resource, the only where a person can be forced to take medications is through a LPS conservatorship, community conservatorship, essentially, in our county. So that's something that maybe people don't know, those distinctions. So again, more details are here if people are interested. But that was eventually approved by our board. There was advocacy on both ends. Our board found a Solomon solution and required that we do both. And so it started small and then it grew. And you can see how what we see typically in the years that we've been doing this work. So again, I won't spend as much time. I certainly want to offer opportunity for questions and answers, but you can see the difference. And for the 30 slots of AOT, which is assisted outpatient treatment, and most folks are referred by others, providers, family members, these people are typically the most reluctant to accept treatment. That's what we've seen in our data for the last several years that we've been implemented. Whereas when people are conserved, we find that they have been in and out of the mental health system for many years. They may have SUD diagnosis, substance use, but they aren't typically involved in with criminal history. But AOT, ironically, we found that our clients do. So this is just something that was interesting. We did not know that we would see this, but these are the trends. Most people who are in and out of incarceration have typically come from an AOT referral. Again, this is just information for people that are interested, because again, I know this was near and dear to NAMI many years ago, the advocacy, and I won't rehash that for those that were here because it got very dynamic, but we wanted to just show what some of the statistics were that we found over the years that we have been working. And so for those that are interested, you can see there, and you can also see the success rates. So for folks that are involved with community conservatorship, for example, a majority of them were male. And once they had been receiving services for a year, this is community conservatorship now, they had about a 90% reduction in hospitalization. That was striking for us, and that's something we thought would be interesting for them to know. Now, in terms of incarceration, and also these are not the people who we usually see in jail, as we mentioned before, it's usually the folks that are referred to AOT, but we saw about a 67% reduction. And same data point, within a year and sustained treatment within the program, we saw 100% reduction in homelessness. And it just talks about the years that we analyzed. So again, for the community, often asking what's the difference? What are you seeing? These are the trends that we saw. And this has been incredibly helpful as we have expanded our full service partnerships and these programs over the years. I think I actually skipped the other one. And so I am going to go backwards. My apologies. This was the slide for AOT and the difference between those demographics, also mostly male, but a little more evenly distributed. They only had about a 67% decrease in hospitalization. So these again are mostly the clients referred by family, mostly people who have been incarcerated or treatment providers or caregivers, community members. And these are people who also have a high incidence already of having been in jail. We saw about an 80% reduction in incarceration. Again, ironically, because they often come with a jail history, but they are the ones who do better as far as not going back to jail. And for, interestingly enough, in housing data, this population didn't fare as well as those who had LPS conservatorship. They often return to homelessness much more quickly, even with the high level of care. So this slide, I won't go through all the details, but for people that are interested, we do have lots of programs mandating for drug treatment. We have what's called collaborative courts. That's even different than all of that. And that's like a multidisciplinary team that come together. A person has committed an offense, illegal. They're on their way either to go to jail, and maybe the judge says we're going to reach a deal, and instead we're going to require that they do this in treatment. They don't have to be conserved, and it's not a Lohr's Law eligibility, but they really work to either avoid long-term incarceration and so forth. Care courts, I started with first, so I won't spend more time, but again, these are different. And collaborative courts like drug court, that is criminal court. So you have committed a crime. Care courts, which is what the governor has proposed that we must all do, will not require that you have committed a crime. So it could be you are in the community and you are homeless and you continue to pose a risk to yourself, you're suffering some psychosis, you may be eligible for this mandated court-ordered treatment. But again, there's no penalty to the person if they don't act. But it is essentially very much like AOT in that it is mandating them to treatment. The difference here is these folks mostly are homeless or at risk. And this slide, again, if everything I've said kind of is confusing, just helps people to organize what those are. And it's really important, again, because when you're looking at the sad metrics that we're seeing, increased surges in people suffering from mental illness, we see this interaction in our forensic system. I will spend very little time on this, but for those that remember, it was a huge outcry in our county around investing, quote unquote, in the jails. That was the tagline oftentimes. There was concern that our Board of Supervisors approved millions of dollars in funding, both to the Sheriff's Office and to our department to provide services to people who are incarcerated. As part of that, that did not come without strings, we were required to develop a plan. So this plan was, again, I won't say much of the details, but a very robust system from lots of sources created these action steps that we were required to implement, and we have been. So this first slide shows short-term goals that we identified that we costed out at about $150,000. And as you can see, nearly everything has been completed and or are in the process of being completed. And you'll see nuances that literally say new things we decided were the right thing to do, even without a directive from our board. Same thing with medium-term goals. There were 9. If you look to the far left, you see that was 8.56 million. That was a significant amount of different types of services that we thought, and changes to the system that we thought would make a difference. And so it's now been about a year and a half that we've been doing this, and we are again moving forward and step by step. Now, what I should note is that unlike the funding that was first, it was our savings. We paid for that, and then our county did provide support in subsequent years to add more staff at the jail. This plan totaled $50 million, of which we have not received funding, but nevertheless, we are still trying our best to implement as much as we can. So we're very proud of some of the things we've been able to implement without funding. But these are things that people are interested in. I certainly can say more. And finally, the long-term goals. And these were very significant that we knew would take way more than 12 months. There were 12 of them. And if you look to the far left, it totaled about $42 million. Now, when we were directed to complete a plan and present it to our board, we certainly anticipated funding. We did not get that, but nevertheless, this is what our true estimation of those costs were. And as I mentioned before, as I said, we applied for 14 different capital projects because part of that is related to this plan. In order for us to, i.e., create a 6-bed peer forensic peer respite, we have to either purchase a facility or build one. Having no money at our disposal because we would have to reroute it from our services, we are applying to the state to see if they can provide support. So there's different areas there, but again, for those that are interested, you can see exactly where we are. And a lot of them clearly would apply to county-wide areas throughout the county and to family members and their loved ones. And this slide just shows costs and what we estimated and what we were able to put together. I'm going to jump over this slide because this final slide, and this references the state funding we are hoping to get support on, shows we have invested about $9.5 million thus far. And that's over $1.5 million to approximately more than we estimated, but we thought they were things that we wanted to do would help the system. So that again is just an overview of what's going on for those people who are struggling and have been. And we did not, after a lot of the advocacy happened, we continued to work. So I hope that's helpful information. The last piece that I think relative to those huge initiatives that I think has really caused a lot of community investment and interest in probably your spheres as well, is the Alameda County Care for Jails Task Force. So I'll back up one second. There was a proclamation, and this again came from the community outcry of the investment in the jails. And a task force was commissioned by unanimous decision from our Board of Supervisors that would again require us, it lists my position as the chair of a task force and several community departments and several community members, including family members, and some of which I know are familiar with you all that sit on the task force. I won't name them specifically, but they are representing the county's interests. The goal of this task force is to come up with a plan that means that everyone will be accountable to helping reduce the number of people in this county that are incarcerated, period. That is the goal, to get them out of the jail. And we were successful in informing our board and informing their opinion that we, behavioral health, could not save everyone in terms of the power of us to require that the sheriff not arrest them, require that the police do not arrest or intervene. We don't have that power, but we do have the ability, and they did take action to require that departments create plans and take ownership in addition to county behavioral health. So we all are required to do something. I showed you what our plan was like, and now that meeting has started. At your leisure, whenever you get a chance, there is a website that people can click on and look at, and you can explore. It says more information about that, but it is a public Brown Act meeting. And these are the goals of that task force. And this is what all are charged to do. And it is a finite time, 2 years, to which a county-wide plan must be developed, and every department will have to participate. And again, these are the updates and requirements and accountability to that task force. And many of you, if you're interested, can get information, look at notes. It is Brown Acted. There is a website, or can participate and even give public comment. It's a formal meeting. On the horizon, as I pivot, is we will continue to do whatever we can to facilitate stakeholder engagement. That means feedback. We have launched a new website for our entire department. I encourage you, if you are bored, to stumble upon it. It is, I'm very proud of how transparent we've attempted to become. Our goal is, as I shared that data with you, is to post that data so it can be public. And so people in the community can hold us accountable and can give feedback to our system, can inquire, can learn, and move forward. The other piece that is really important, we're working on the African American Wellness Hub. We're also launching and involving a lot of work in our API community, or AAPI, as well as our Latino community. So we have countless investments in really an equitable and a system change that can change the tide. For those that are following in this county, mostly statewide, it is sad to say that, but for COVID, individuals who have lost their lives mostly are from the Latinx community, and they have been among the most hardest hit for transmission. In this county, and this county has done a significant amount of things with our teams, many of which were deployed from our department as well. African Americans were highest risk to die, to be sick, and to receive negative outcome, unfortunately, by being exposed. And that was striking, because in this county, the majority of individuals are not African American. And so that was an interesting metric that was sadly revealed. So something is very clearly different. And that is also the same with African Americans being incarcerated in Alameda County, as well as inpatient hospitalized. So our health equity work, both with the African American community as well as the Latinx, API, we have a really huge, now robust division and plan working to support the community. But I mentioned those things because that's where the accountability comes back, and the access that I mentioned before. So now I know I have spoken so much. I hope many of you are still awake or are not looking at, well, I was going to say TikTok, but that's my kids. I'm sure you all No, I won't tell if you won't tell. I'm going to stop sharing. I thank you just for the opportunity to speak a little bit about it. And I hope at least some of it was of interest to you. There's so much more I can talk about, but I don't know that you all can tolerate it. So I'm going to stop talking and open it up if there are questions or concerns, and I will defer to the moderators in terms of that.
So first of all, thank you very much. We do have plenty of time for Q&A. So I would like to ask everyone if you want to type your question, we're watching it, or you want to just raise your hand. There is a little reactions, right? Icons. Raise your hand and ask your question if you're interested. We'll get to you. Please take your time. I personally have a ton of questions, but I'm not going to take over the conversation. So I want everyone to get a chance to ask the questions.
Cindy has her hand up, and so does Janet.
There we go. Go ahead, Cindy, you first.
My question, I don't know if you addressed anything about this, but recently Alameda County Behavioral Health has teamed with, I think it's just Livermore, it might be Tri-Valley, to acquire a site that they're going to have for, I think it's for substance abuse inpatient. It's over on, oh dear, now I forgot, close to Junction. It's on Junction Avenue. The thing is, it's very, very close, within 2 blocks of an elementary. And I was quite concerned about that. I didn't know if there would be more discussion regarding this. And around the corner, within probably less than half a mile, there's another elementary. So I don't know if you know anything about this or can address it or tell me who maybe I could talk to about it.
who you need to throw rocks at? Well,
yeah, because I go pick up my grandkids twice a week. I know right where this is. And it's like, no.
Good question. Oh, I'm glad you asked. So yes, I know all about, I'm intimately, I don't know addresses, but as I mentioned before, I did speak about it. I didn't go through each site. That was one of the 14, well, let me back up. When the state released multiple millions of dollars, one of the things they said that was each site had to be shovel ready. And so what that meant was it had to either already be built, or literally you have people, I can just imagine people with shovels. I don't really understand all that part. Our GSA partners did. The city of Livermore actually approached our department, and I understood that they had been in talks, as well as our board had interest in, to see whether that site would meet criteria for an application to submit. Now, that particular site, we are certainly willing to support and be of assistance, because quite frankly, we don't think, for many of us who have been around for many years, I won't date myself, but have never seen the state invest this much money at one time ever. And what they have done is waived a lot of the requirements that often precluded people from applying, but they will require safe locations. And so if there's any concern, the state will not approve it. That particular site has not yet been submitted, because what the state has done is rolled out applications in phases. And so those 14 that I mentioned were the first phase. They represented peer respites. They represented lots of different programs. The ones you're referencing, we were to have submitted actually by May 31st, but the state slowed that down because many people were applying. And they basically, whatever money is left over, they'll open it up again. And so that site and others will be eligible to apply for. So I think that's kind of what we know. What we have seen is some of the sites are for treatment, because that's a requirement. Part of the state says you must provide treatment and care to behavioral health, including SUD. Any applications that are not committing for 30 years to do that need not apply. That's the first hallmark. And they also said, clearly it has to be safe and vetted and so forth. So any facility that met those high standards could apply. Many have already been ineligible. So we submitted those that met that. We don't know what will happen with the 14 we've submitted, and we don't know whether, i.e. that particular site will be submitted in October, since the state has had such a huge outpouring of interest in state money that we'll probably never see again in our lifetimes, to build buildings specifically dedicated. So, I won't speak to your local leadership, but that particular site, so please, I didn't say that. That particular site, though, they did approach us, and we did outreach, broadly. Please come to us if you have thoughts. And that one we hadn't known about or seen.
Well,
And
when
is
they-
that the one? It's a former church?
It's a former church and it's empty. And
Yes.
when the city had it on the agenda, I didn't realize it was going to, that it was happening. So I have reached out to my council member, but so I'll be watching the agenda. I have no problem that I know we need treatment centers, but one of the things it talked about was also medication for substance. So my daughter who walks by there in the morning with the kids, it's like, we're going to have people waiting there to get in. I mean, it's just a little too close, I think, to a lot of little people. And so I guess I'll keep my eye open on what the city's doing.
Yes, and I don't want to, we love our partners. I hope you don't see it. I'm not pointing fingers.
No,
but
I think,
and in
are
that
they, did they survey the neighborhood or anything? It's like, all of a sudden, it's like, you're going to put this here where? So,
Yeah. Well,
okay.
Yes, there are many different steps. And again, we
Okay.
won't be able to submit until October. But then that site, I don't believe it's just substance use treatment. I do believe it's also providing some
Said something about inpatient.
board and care. There may be
Okay.
some pure respite. It's a huge facility, as I understand it. Pure respite. It may allow for people to get short-term residential support. So it's a mixture of all different types of services, including those who are suffering from substance use issues.
Okay.
But that was not, to my understanding, not just to be a substance use facility, but to serve
I think
as
it's
many people.
just like all of a sudden it's like, and it's close to the school. I mean, right.
I actually don't have a problem with it, but maybe we can talk about that more, Cindy, because we're desperate for that.
Just,
I feel like I need more information.
well, and it kind of slipped by on the city council and it's like, wait, they had a
Oh, I
meeting
was
about it.
going, yeah, good, wonderful.
I'm all for something
Yeah,
like
I
this.
know
But
you
I
are.
don't think
I
it
know
should
you're
be
concerned.
so close to the,
I'd want to know the
Elementary.
statistics on people with, that would be eligible for that facility. I want to know all the things. I mean, I'm excited. I'm hearing board and care and I'm hearing these other services.
well, somebody,
I'd love to
the
hear.
county is reaching out to Livermore. So, hey,
So the question is, from that 14 facilities you mentioned that we applied, was there anything in East, our Tri-Valley area outside of the one we're talking about, which I understand not submitted, right? Not yet.
Correct. Yes. Well, I'm sorry. I'm saying yes. Let me make sure I'm answering your question. Yes, we try to, people or organizations, even jurisdictions who approached us, and part of our forensic plan was to make sure we have a broader spread of facilities in this county, because we do not. And we concentrate them in particular areas that, quote, have the greater need. But what we are hearing is that there needs to be support across the county and availability. So that particular site, although maybe not in each city that's nearby, there was a goal to attract as many different types of services because the building is so large. And I do understand that we had explored initially, based on the city's request, whether there would be an appropriate need for a sobering center or just a SUD. The statistics that we saw didn't show that just that need would be served, but instead a variety of types of programs would probably be better, because there's a demographically different set of needs there. So, but for now, I don't believe it's been submitted. We got notice that the state said, hold on, and then we'll get to you later. So we're still on tap. Before that will happen, the children's sites are eligible. So we're also gathering information now and working with partners. People are approaching us. We're approaching facilities to make sure that children's needs are supported also when that round comes through. But I thank you for your feedback, and yours is not the first to say that. That's been our challenge. There's a lot of interest, but the location.
it was just like, wait, what? Where? And I'm all for it, but so I will keep my ears open for what's going on in the city.
So let's move to our next question from Janet. I think Janet had already, I know Rosemary, you have your hand up, but before Janet, just, you're muted if you're talking, we can't hear you, Rosemary. But Janet goes first because she's unmuted.
Okay. So I'm interested in mandated medications for my daughter. So I have some questions about care court and LPS conservatorship. So through care court, could somebody be mandated to take medication if they are not homeless, but she's a revolving door, gravely disabled client who's in and out of psych hospitals frequently, but
Good
she's not
question.
homeless?
No, they would not. Care courts is not like being conserved. They cannot forcibly require medications. They can recommend you to a provider, or they can do an evaluation that recommends treatment. And it's essentially a report, a certification that said you need treatment, you're ordered to go to treatment, but there are no penalties if a person doesn't. And it's not a legal mandate. It is, for lack of a better term, it's relying upon the robe effect very much as assisted outpatient treatment. And so that's why I'm glad you asked that question. They will not be able to be required, but certainly they will be back into court periodically to report to the judge their progress, as well as any provider will give testimony about it, and the judge can continue to mandate them to participate, hoping that they will engage. And the housing that they will receive, because that is now that has been funded by the state, different housing opportunities. And the state has also put pressure for people to provide support legally. So there can be sanctions. And as I said, even our county department will be sanctioned if a person doesn't successfully place somewhere, even though there's no additional funds or services for us to do. We will just have to figure it out how we can accommodate them. So I hope that answers your question.
Okay. My second question, she's currently living at a mental health recovery center. And it looked like there's some subacute facilities from which you could initiate LPS conservatorship, but I don't know if MHRC is the same as a subacute facility.
Yes, if it's locked. If it
It's
is
not
locked. If it's unlocked, in our county, and a lot of folks use subacute synonymously, although other places can initiate referrals for conservatorship, the primary ones are subacute or John George hospitalizations. If a person has been, goes to John George for the first, the first 72 hours, then they're extended 14 days. And then they look to extend the hearing, they can have and involve the courts to petition for community conservatorship. So for the most part, it's locked. But we do work with our social services agency, and they will review, but for the most part, truthfully, that's where people come from.
I tried to initiate it on our last 5150 at a psych hospital, and the psychiatrist was uncooperative, saying that LPS is for homeless individuals and my daughter's not homeless. Therefore, she should not have it. So we'll just keep getting 5150s because we need to require medication.
I won't speak about what the provider said, but I will say it is not a requirement that a person be homeless. It is a requirement that if once you're conserved, as I mentioned, the conservator's office will require you to live in most cases in a locked facility. With very few exceptions, community conservatorship could be a possibility in an unlocked setting, but you have to be conserved first, and you can force meds. And usually, I'm not sure facility, you don't have to say much about her personal information on the line, but you can reach out to me and perhaps I can connect you with one of our leaders. But for the most part, that actually is one of the requirements or the eligibility requirements. The more times people cycle, they come to the radar, they should be referred immediately to that type of program.
Thank you for your help.
You're welcome.
Go ahead, Rosemary.
Okay, it's kind of circling back to the last discussion with Cindy. Marcia, can you clarify, is the location Cindy's talking about the same one that was that Vineyard 2.0 that you visited the groundbreaking of, or is that a different location?
That's different.
That's different. This is at Junction and Walnut.
Oh, and Walnut.
What you're asking me about is housing for the homeless, and that is at
It's on Livermore
South
Ave.
Livermore, and I'm trying to think of the cross street, but it's,
North Livermore and,
oh, North Livermore, sorry.
yeah, it's North Livermore.
it's
It's
just-
between Chestnut and Walnut, so.
Yeah, it's a few blocks from or between Chestnut and Portola. So if you drive by there, you can't miss it because they're doing.
Right, right. But when she said that this other one was a former church, then I was confused that maybe it was the same place
Oh.
you were talking about, because wasn't that also a church location?
I
Yeah, the
don't-
one on North Livermore was a church.
Yeah, yeah. And I thought you said that the
The other one was a church too.
Yeah, that's why I was a little
There's a lot of
confused.
churches in that area.
That was the same place. Okay, that's all I wanted to clarify on that point. But I do have a question for our speaker. I know that the session's being recorded, but is there also like the slides available to, or a screenshot of the slides of particularly of the charts that you had presented?
Yes, absolutely. I've made them available and I can also, again, at your, whatever makes sense, I can even add that to the chat myself but yes, the slides are absolutely available.
Okay, great. And then the third thing, years ago from Behavioral Healthcare Services, I gotten this, I don't know if you can see it at all or if it's clear. It was a handy little booklet called Quick Guide for Families and Friends Providing Care and Support for People with Mental Illness. And it was very handy and very complete, but this one I have was from 2010. So I'm wondering if there has been an updated version published.
I have to admit your background blur is being very rude, but I can memorize, I can see some of it. I will have to follow up and see, and I certainly can circle back. I know
Yeah.
that we have updated several documents. I don't know within the last 3 years if some of the resources have been.
Yeah.
And the title again was,
It's called Quick Guide for Families and Friends of Persons with Mental Illness.
I can speak to that actually, at least the history of it, because it was written by someone who was on a family member on the mental health board,
Yeah.
and Joe Shimizu, and he was instrumental in getting this put together. This is a family perspective for family members in Alameda County and navigating the system and helping their loved one. And some of it's probably outdated. It just sort of faded into the background. It is helpful, but books, who uses books anymore? I mean, I'm, this is-
Oh, I think
maybe it's online. I don't know.
yeah. And
Yeah.
it seems like FERC got involved with it at some point too.
I'm not, I don't remember that at all, because they have their own materials
Yeah,
that they provided, and a lot of it's online.
yeah, but this, I
Good.
mean, the front of this says Alameda County Behavioral Health Care Services.
Well, they worked with the families
Mhm.
to write this, so it was
Yeah.
collaborative.
well, and thank you
Okay.
for the history. I wasn't aware of that, but I will certainly check to see if we have any physical resources. I don't worry. I just got rid of
Fashion,
my
huh?
day runner. I still had a day runner for a few years. I still have it. There's nothing in it, but it makes me feel good. So I understand completely. My kids laugh, but that's all right. I'm not on Facebook either. But I will follow up, and if we are able to, there's some recent publications that will be helpful.
All right, thank you.
But
You're
if we have a PDF version that we can reference, that's fine too, if it is a website or
Okay, absolutely.
Mhm.
we all can relate to the fact that when you're in a moment of need and you just don't know where to go, and that's the scary part. It's easy for us to sit back now, all calm, and just discuss the topic.
Mhm.
But that's our job as NAMI.
Yes, let me tell you, we try to support each other, that's for sure. If there's no question, I want to ask my own question here. Who wants to ask the next question? Let me make sure I capture. Okay, so I go back with the numbers, okay? Alameda County has 1.6 million, if not more, population. And everything we read, it says if you take mentally ill, 2-3%, I'm just being conservative, right? And heck, I'll say 1%, right? That's 16,000. That's a lot of people. And then and I'm not saying this just not knowing. I've been in the system with my son, several years, all right? So there is waiting list everywhere, okay? We just recently been in Villa Fairmont, God knows with, John George in and out. But when you have a loved one, you don't know you want them there or you don't want them there. You don't know if it's causing more trauma, but you have absolutely no choice, right? So then we were hoping like, Villa Fairmont's going to solve our problems. We waited so long, and I walked away with more sore spots than positive. And it was COVID, so I don't want to point fingers. COVID didn't make easy for any of the health providers, right? We understand. So that said, all this coming together, I just heard the numbers with AOT and then the CC care courts, 25 and 30. That's like so little. I worked very closely with both services. They all care providers have different programs, and the waiting list. And we're at NAMI, people come to us. How do we address these numbers?
So we have over 1,000 actual, I don't want to say slots, they're human beings, but we have 1,000 vacancies for that type of service. And meaning a full service partnership, as I mentioned, and that's just that service. And, we are still planning to expand. So just for that particular service, and if I can be frank, there was a lot of feedback from the community during that time. 2014, 15, 16, it was very, very painful for the community, depending on what side of the fence, quote, that you looked at for community conservatorship or assisted outpatient treatment. So the County Board of Supervisors actually gave us the direction. And initially for about a year, we weren't even able to have those many slots. We had a pilot. And so it wasn't until about a year and a half that we were able to formalize and no longer have a pilot. So that number just means in any given time, there are that many court ordered treatments. And so every day, I'm sad to say I'm not proud of it, but after the court makes the order and determination, I, as the director, also have to sign those orders to affirm. And so they're just a specific type of service. Some of our county boards members, and I won't be specific, but have advocated publicly that they are in favor of expanding those numbers. Others have not. And so we certainly could, and we have been expanding the type of treatment that is the same type of treatment that those two programs get. But we know that it involves much more of a it's less of a unilateral decision, because those are true programs that can cause people either joy, that the court is involved or not. And so we walk that fine line, but know that there's, again, hundreds and hundreds of different programs. We have youth, full service partnerships. We have variety, we have forensic programs, and that's just the type of service that you're describing. And so we serve, I want to say upwards, you said 16,000. I wish we served close to, depending on what's going on and what metrics you're looking at, sometimes 40,000 individuals in a year.
Yeah.
And that's the sad part. We're seeing so many. The other piece that I'll say, and this is something our providers, we are our providers essentially. We'll take the egg, the rocks, I'll duck. But they are helping us to do the services, and we do our best. But the truth of it is, and this is where our definition, that's why I'm certainly just spending time to explain it, is it doesn't apply to, for example, so there's two things I'd like to be frank about that is public, that I think, again, you all may be interested in. And I'm sure if you just Google us, you will see that there is litigation out there. So I want to talk about that a little bit, because I'm trying to educate as many people as I can. But the first thing that I'll describe is that, with the exception of sites and facilities, for example, like John George John George is actually, and for those that know the history, they used to be part of the county, and now they're no longer, they're part of the health system. And that's actually where I used to work, oversaw all of behavioral health services for the health system. And then I came back, which was a blessing to really get a sense of what that looked like. But I say that to say, if you looked at John George at the state, it would look as though it has, 80 beds instead of the 69 that it has. Many years ago, it converted PES from a short-term inpatient short stay unit to PES to compensate for the need. It now, right now, it falls under the hospitals. It doesn't fall under the county, although we fund it multiple millions of dollars every year to run. I say that to say also that you'll often hear if there are not beds in the locked units, there is not a state sanction that will happen because it's a different type of service.
Mhm.
However, as a mental health plan or a substance use plan, we are required to ensure network adequacy. So we are sanctioned and we are audited 3 and 4 times a year by the state and other governmental agencies to make sure that we have sufficient services out there. And what they do is they look at the number of individuals, they look at hospitalizations. Sadly, we are one of the highest in the state
Yeah.
for hospitalizations in John George, but they look to see what we offer. And they help us, quote unquote, as the state run managed care or state governed managed care plan, locally run, they will give feedback as to where we are in our system. And if we have more services here, oftentimes the state will recommend pull that back. You need to have more adequate networks in this part of the county and for this service. So they give us feedback all the time. It's my dance,
Whose day?
that's the state.
State. Okay.
Yes, the state. According to the state, and this is up for debate because that dovetails to the litigations. And please feel free, you don't have to hang up on me if I'm talking too long. I'm more than willing to curtail it when my time is up. But I did want to just end with the litigations, and it is public. The county did experience, and it's been settled. There is a consent decree for what's going on in the jail. And that's the BABA litigation. And that basically said that there are many people suffering in jail with behavioral health. You need to have more behavioral health people to help them. They did not, the lawsuit did not, and this was a federal class action lawsuit, did not say whether they should be in jail. They did not argue the benefits or the humanitarian cause to have no one in jail. What they said is, if they're there, you must serve them. And so we do. That lawsuit is done. There's also public discussion of litigation, and I can acknowledge that. It's been, ironically, even YouTube videos have been created around it, so I can say it publicly, that there's 2 parts: Disability Rights of California, as well as the Department of Justice, the federal government. Those are both being played out in federal court. Both are alleging different parts of Alameda County. That much of it predates myself, but here I'm here and committed to help the county and do whatever needs to be done. All of that long-winded soliloquy to say, part of that concern is that Alameda County, IE, has too many locked settings. Now, we know the community does not agree, but the assertion of Disability Rights of California, for example, contends that we overly use locked settings in this county to treat individuals when they can be treated out elsewhere through outpatient programs, through other means. So again, I have my own thoughts. I won't get into a philosophical debate, but I say that truthfully because when you're in active litigation in the courts, the federal court is working with you to address it and come to some conclusion. We are trying our best faith effort to address what the need is, as you said, that people are still having to wait to get into a locked unit. So clearly there's a need, although the state numbers don't bear it out. The state
So
numbers.
how do we bring those sides together? I mean,
that's our hard job. We are actively talking and advocating through legal means to talk about what the community needs. And we acknowledge that we certainly don't want to create way too many locked settings, but we know that there's a need. We also are trying to create lots of options, residential, everything that we just described, every reason why we submitted 14 applications or with our county partners and everyone else is to serve and create other settings too. So we have to do both. We don't know why, we have thoughts, but this county does provide resource. And so many counties, people do gravitate here, whether they come from San Francisco, whether they come from Custer County. We do have people that we see even from Santa Clara County. We try to coordinate their care, help them to go back. But there is something to be said about the Bay Area that does attract them and they stay. And so our numbers may not look like what the state sees because the people are more transient. So I'm sorry, I hope that wasn't too much information.
No,
So
no,
that's what our job is about doing.
Yes, yeah, if anything, I want to add that Alameda County takes everyone, but I've looked around because of the need when we were waiting. Santa
Yeah.
Clara, some of the neighboring counties, then none of them are as friendly as we are taking on everyone. And you talked about John George, right? I mean, again, no one is dreaming to be there, family or a person who needs the help, but when they need a help, there's nowhere to go. Local hospitals cannot house them, cannot take care of them. There's nowhere to go, whether you have private insurance or public for that matter, right? And I've been in this last 8 years, and my take is, and not just that, that's a big picture Alameda County, right? Then you take East Bay. Okay, to Tri-Valley area. I mean, Alameda County is East Bay. Let's focus on Tri-Valley. We have a pocket of community where Alameda County people will say, oh, there's no need in that section of the world. But let me tell you, there's a lot going on. And we have families carrying the burden, don't know what to do, how to deal with this. They don't want to kick their kids out to the streets. Okay, we're taking so much on our shoulders. At the end, we have no choice, you know, and gosh, it's the hardest thing one has to do. As you understand, you're in the field, and NAMI Tri-Valley is really working very hard to bring this housing, the programs, and the commute to whether it's Hayward or Oakland or Berkeley. And I've done it. I drive 50 minutes to go to Berkeley to see my son once a week. And then now he's in Hayward. I go, oh, that's closer, 40 minutes, right? And, you know, it's very difficult. There's just not enough housing to support people close to their homes.
All I can say is yes, what you said. And for that reason, it's a risk. But even those facilities that we looked at, that I mentioned, that's why we're looking at a combination, including locked. And it's the right thing to do. And we just know we have to go through that process and hope that the courts find that we're doing the right thing. But you are exactly articulating what our goals are right now, to spread out through the county. In one of the slides, I talked about Washington Hospital. We're trying to find different sites, different locations, farther and more diverse across the county, and not centralizing them and to where just the data shows, because what we think is people aren't showing up because they're not resources, as opposed to there's no need. That's harder to be a managed care plan and talk about unmet needs. That's not how HMOs deal in terms of with the community, but we're trying to have those conversations. So I can't argue with anything you said. In fact, I'm the choir, so I'm saying hallelujah to what you said, but I think that's what our hard work is about. And to spread it through the county, even if we have to have a multiple area approach with facilities in an area that all parts of the South or Southeast or farthermost parts of the county, even unincorporated, we're willing to do that. And so that's why we're applying and trying to get as much as we can done.
Oh, yeah, no, I appreciate that. I mean, we're a team, and if I were to follow up on one thing, I would like to understand how those numbers are generated from state. Who sits in their office and comes up with this number? Who provides this? Is it the hospitals? Because what we've seen also, you know, the whole revolving door concept. I've been in the situation where we had to call several times to the police, you know, and it's almost triggering for the family members to do that, right? As much as the person who's dealing with the issue, when he's going through these manic episodes and the phone calls have to come in, it's really, really unnerving for any side. And he knows what to say, what to do, and police know, it's just like, okay, we're scared calling, we don't know what else to do, and they won't take them because they have their instructions very specifically. So
that's a long, I'll be brief, and I see a hand, so I'll be very brief. The state calculates it on Medi-Cal beneficiaries, and that's why I spent that time to describe who we are. The need has shifted in California, but the methodology to determine what's enough was determined based on Medi-Cal beneficiaries, literally who's not insured or who is uninsured, and they take an extrapolation. They look to see what was the utilization and what percentage of the Medi-Cal population does one expect to have a mental illness. And then that's when they say, okay, you must do this managed care plan. And that's what we're doing creatively, but we're trying to think outside of the box because we know what the local needs is, despite what the state requirements are suggesting. So.
Thank you. Go ahead, Marcia.
Couple of things. Janet has just put a chat question, so I want to make sure that doesn't get ignored. And then Dr. Tribble, could you explain to the audience what a full service partnership is? So I know what it is, but
Yes,
they may not know, and it's important that they hear it.
absolutely. And I know I'm on for time, so I'm going to use very layman, simple ways to describe it. I'm not sure if you've heard of wraparound programs. They started with kids. It's essentially adult wraparound, and the motto is whatever it takes. So once a person is enrolled, they can have housing vouchers, they can have housing, they can have free, first and last month's rent. People can buy food for them, clothing, give them Target cards, feed them. They can transport them. They do whatever it takes to keep the person stable. And then they provide behavioral health services or connect them. And they also are operating on an emergency 24-hour basis. So unlike the traditional outpatient where you have to wait for business hours, you have to have access to them 24 hours a day. That's a state requirement for funding. And that comes from MHSA. That's a requirement. If I wake up at 3 a.m. and I need to talk to my case manager, give me a number and someone has to call me back or even respond. So that's the quickest way to describe what an FSP is. And so that's why I mentioned in our county, we have over 1,000, and we know that there's even additional need, so.
Okay.
Janet has something in the chat, Armine.
Okay, I see a few questions. I'll go backwards. My daughter was is it okay if I read that? Or?
Yes, please go ahead. Yeah, I was going to read it. Go ahead.
Okay. My daughter was refused admission by a psych hospital in Concord because she's too difficult. They didn't want her, but they hide behind saying we don't have the one-to-one staffing she requires. Is there a hope of changing the fact that a psych hospital can decline to care for someone if they do have a bed? I'm glad you asked that. I'm glad you didn't put the name of the hospital. I appreciate that. What typically, I'll say it this way, private hospitals technically are not held to the same standard for the general public. So they technically can refuse care, and sometimes they do. That's, I want to be honest. Typically counties who have contracts with county behavioral health or provide safety net help to people who are uninsured do not have that freedom as much. So our staff and our leaders, when we hear these cases, because they don't just happen at a private hospital, sometimes they happen in our county funded facilities, which I won't name, or we buy beds in some facilities. We will push and they will be admitted unless there is a medical reason why. And so it depends on, and again, I don't want you to say more about it, but I would encourage whatever, I know the director for Contra Costa, but I would encourage you to reach out to the leadership in the county, because if they have any relationship, or even if they don't, they have teams and leaders like we do that can help find a bed, because that's what's going on in the Bay Area. The need is higher than the amount of beds and space. And so it sometimes takes push to lean on our partners that are privately run. So that's what I encourage you. And how do I reach you or your associates for further discussion about LPS conservatorship, phone or email? So I will put in the chat my email address, and I'll share my staff will say, Dr. Chilber, you did what? And if you email me, I will certainly link you to the right person, because I'm just doing my best to reiterate the brilliance that comes from my team. And so I will connect you. I know the folks that could help give more information. They're really, really smart. And leaders that oversee it now used to work for county social services, so are fluent in that. And thank you for the positive feedback about the presentation. I really appreciate that. We are really trying our best.
Yeah, no, we thank you for your time. You're always there. Your door is always open, and we totally appreciate that.
Thank you. Thank you. Thank you so much. And I do hope that if you haven't already met her, Stephanie Montgomery, again, is our new health equity officer, and she oversees services for our family members. Many of you may know Rosa Warder, but now there's a new leader who's helping to do some pivoting, bringing in more staff, really trying to recalibrate and get a better sense of it. So if people are interested and would like to reach out, I'll put my name, my number in the chat. Number, they really will kill me. My email, so that I can make a warm handoff to the right person. I will certainly do that. But I just say that she's really helping to reshape, and there's an opportunity here that we are engaging, as well as patients' rights, and she oversees Office of Peer Support Services as well.
Thank you. If there's no more question, I have one quick one.
Absolutely.
It depends where it goes, right? So we discuss all these services, and predominantly a lot of it, and most here are talking about SMI. Okay, we won't talk about definition. I think most people here understand serious mental illness. A couple of times people approach me and the question has arose where you start off with a diagnosis, and then down the road they say it's personality disorder. It could be both, or it could be one. What happens with the personality disorders if it's diagnosed when it comes to all these services?
Oh, that is a wonderful question. It's incredibly complex. I have 3 minutes, so I will try to be as succinct. And that's one of the reasons why I started off by talking about what we are as an HMO. And it is not right, but what typically happens in county behavioral health systems is that used to be, and it's still mostly, an excluding diagnosis. So if a person is having trouble, and most of it's because they have a personality disorder, technically they're ineligible for services. And so, and it is counterintuitive, because if a person has, quote, a personality disorder, and they're breaking bridges, wait, is it breaking bridges or something? It's, well, you know what I mean? They're
Burning bridges, yeah.
burning bridges. Maybe they're breaking them too. They're really having a lot of challenges. Those are the folks you want to help, but technically they are excluded. Now, if they have a personality disorder that is secondary to a mental health condition or a substance use condition, then they are eligible for services, but it cannot be the predominant reason why they're suffering. Sadly, many people with personality disorders use their personality. It's almost like it flares up when their mental health system flares up. It's hard to see it because there's such a reaction to what they're going through. But there are specialty providers who provide lots of different types of treatment modalities. DBT is a famous one that people often use for borderline personality disorder, but there's certain treatment modalities really helpful. But the key to accessing care, because we were all set up as HMOs, is that the personality disorder cannot be the primary reason for seeking care. It must be secondary to a medical or behavioral health condition. I hope that makes sense.
Yes, yes. Wow. And that applies to SSI, SSDI, all kinds of help from the government too?
Yes, oftentimes it does. Very rarely, I've never heard of a person, i.e. getting on disability for personality disorder, because the thought, if it's quote unquote characterological, it is either long-term, pervasive, can't be changed, or if it can be changed, it's a huge amount of resource. And most of the time it's how they cope. But it can be if it's part of a medical condition, or not part of, again, if it's secondary and they have it and they can get the treatments to support it.
Thank you for clarifying. You know, the communities at large need to worry about those things because a lot of the fear the communities have with mental illness, it's not really from SMI as much as the personality disorders that really mess up that whole. People don't understand mental illness, and we've been in it. We're trying to educate ourselves constantly. I mean, I'm still trying to understand, how does one get diagnosed? If you're taken to the hospital, you're taken to the hospital, by default, it seems like, oh, schizoaffective. And then they like, who diagnoses? How much do they even know? What do they do? Villa Fairmont, I've been asking this question, who decides? What does the doctor, and it's like, I still don't have an answer.
Well, I know we're at time. It's very, very complex. I mean, I don't know if it makes me, I don't know what it makes me, but I enjoy to helping people who have personality disorders. Sometimes they enjoy me a little too much and I'm saying, wait a minute, but it is very complicated, and it is counterintuitive how you can help them. And it is a specialty, I'll just say it that way. So the persistent family member who can hang in there with it and with them, and it can really make a difference. But oftentimes they do burn bridges, and that's one of the saddest things, because they respond well with the right type of consistent treatment. And then their mental health systems and substance use issues oftentimes diminish. So.
Thank you. Thank you for helping clarifying. Any last comments from everyone? Anyone?
Thank you.
Yeah. Janet's giving you thumbs up. I give you 2 thumbs up. I thank you. We'll be in touch.
Thank you. Thank you for your comments for me.
You are most welcome. And I did put my email address in
Where
the
is it?
chat there. So
I
feel
see it
free to
now.
email me and I will connect you to the right person at any time. So take care. Thanks for having me.
Thank you very much.
Well, and you do have my presentation. I believe yes, the PDF version is just shareable, and have fun. All right, take care. Thank you, everyone.
Thank you. And folks, I will send it to the board, and I will send it. I don't know if you're interested, if you can just contact us, we'll share the presentation, because the recording will be going on YouTube, but we cannot put the presentation.
No, but you know what? Now that Kim set up that Google Drive, we might be able to put it on the Google Drive, and then I can put a link on YouTube to the Google Drive.
Okay.
Okay, we'll
So
talk.
Lois, you have a copy of the presentation. I would already, she replied you were copied. Marcia, and you were copied already. So I knew that was going to come. I set you up early. So thank you, Dr.
Thank you.
Tribble.
You're
This
most
was great.
welcome.
Mhm.
Take care. Thank you.
Thank you. Thank you all.
All right.
Thank you.